In this next section, we will review initial ventilator settings, focusing primarily on the various modes of mechanical ventilation, but also discussing the set rate, tidal volume, FiO2, and PEEP. At the time a patient has to be intubated, your goal is to rest the patient, i.e. to minimize all excessive work of breathing while resolving hypoxemia. There are four basic general modes of mechanical ventilation used commonly in practice today. These include synchronized intermittent mandatory ventilation, assist control ventilation, pressure support ventilation, and pressure control ventilation. In the next several slides, we will review each of these. In patients who are intubated and connected to a ventilator, the ventilator will measure the airway pressure in the tubing returning to the ventilator. That pressure should be equal to atmospheric pressure if the patient is not receiving PEEP, or it will equal the PEEP pressure as selected by the physician. When a patient is breathing spontaneously while intubated, inspiration will be associated with a drop in airway pressure and expiration with an increase in airway pressure. Once the patient exhales and is not breathing, there will be a return to baseline PEEP, with the next respiratory cycle indicated by a drop in pressure as the patient inspires, and again a rise in pressure as the patient exhales. The size of the resultant tidal volume depends entirely upon the balance between the patient's effort and strength compared to the load placed upon the respiratory system. In spontaneous breathing, it is pretty clear that the patient does all the work of breathing, and the tidal volume again depends entirely upon the patient effort and lung mechanics balance. In SIMV, there is a backup rate such that every so often, based upon the rate the physician dials in on the machine will deliver a tidal volume of a given tidal volume set by the physician. So intermittently, the patient will mandatorily receive a volume of ventilation. When the machine pushes that breath in, the airway pressure will increase. Once the tidal volume has been delivered, the valves open and the patient is allowed to exhale and pressure will return to baseline. And this will happen as frequently as the physician has set the backup rate. If the patient wants more breaths per minute than has been set by the backup rate, the patient is allowed to take spontaneous breaths, those breaths being depicted here. During the patient's inspiration, the airway pressure would reduce. During expiration, airway pressure would increase. The size of the tidal volume on the IMV breaths is set by the physician. The size of the tidal volumes on the spontaneous breaths would of course be determined entirely by the patient. The maximum pressure necessary for the ventilator to deliver the required or set tidal volume would be referred to as the peak pressure, and that peak pressure would be dependent entirely upon the size of the tidal volume as well as the patient's underlying lung mechanics. In this representation of flow rate, airway pressure, and tidal volume, okay, I would like to go back just to the beginning of this slide so that I am not showing the web reference. In this graphic representation of SIMV ventilation, in the top graph you can see the flow of air into and out of the patient. As air enters the patient, there would be a positive flow. As the patient is allowed to exhale, there would be negative flow. Airway pressure can be measured on the second curve. As the IMV breath is delivered, airway pressure would increase. As the patient exhales, it would decrease. In this particular example, the patient has two intermittent mandatory tidal volumes being delivered, but in between those two mandatory tidal volumes, the patient is allowed to breathe spontaneously, initiating inspiratory and expiratory flow. But you can see that these breaths are spontaneous because airway pressure is negative during inspiration and positive during expiration. The size of the tidal volume on each of these breaths varies. As you can see, the intermittent SIMV breaths are of a standardized set tidal volume, whereas the patient's spontaneous breaths in this particular example happen to be smaller. The reason these breaths are smaller is simply a manifestation that the set tidal volume is larger than that which the patient either needs or is capable of generating given their relative strength and the mechanics of the respiratory system. As illustrated in this example, one could imagine scenarios in SIMV where patients have large IMV tidal volumes with intermittent small patient volumes, which could result in excessive respiratory effort and patient discomfort. So to review SIMV, the patient will do all the work of breathing on their spontaneous, so-called extra breaths, and they in fact do some work of breathing even on the breaths when the machine is delivering a tidal volume. This concept will be reviewed in another section. The tidal volume of the spontaneous breaths depends entirely upon patient effort and lung mechanics. Overall, this is not generally a good mode for resting somebody, as if the patient triggers any additional breaths per minute, that extra work of breathing can, at least theoretically, result in respiratory muscle fatigue. In assist control or volume control ventilation, the machine will again intermittently deliver a mandatory breath of a tidal volume set by the physician. That is very similar to SIMV. Compared to SIMV, however, if the patient wants an additional breath, the patient would begin breathing just like in SIMV. But rather than breathing spontaneously, doing all that work of breathing on the patient's own behest, once the patient breathes in enough to drop the airway pressure by a small amount, the machine is triggered to deliver the same tidal volume the machine would have delivered in a moment anyway. So in assist control, there are intermittent mandatory tidal volumes of a set size delivered by the ventilator, and if the patient wants additional breaths, the patient merely has to trigger the machine to deliver the exact same size tidal volume the patient would have received in a moment anyway. This triggering can be done by either pressure drops within the airway, as illustrated here, or through a process called flow triggering, which will be reviewed at a later date. Regardless of the mechanism of triggering, the work of breathing to trigger is quite small, minimizing patient effort. The tidal volumes in assist control are all of the exact same size, whether or not they are on schedule by the machine or so-called extra or triggered breaths initiated by the patient. The peak pressure necessary to deliver the tidal volume will again depend upon the size of the tidal volume and the patient's unique mechanics. In this illustration of assist control ventilation, you can see that there are two breaths in which the patient triggers delivery by inspiration, triggering the machine to push, i.e. pressure goes up, a given tidal volume that the physician has set into the patient. Once the breath has been delivered, the valves open, the breath is exhaled, and there is negative flow rate. These circles illustrate the patient triggering, and as you can see, the flow rate, the pressures, and the tidal volumes are consistent from breath to breath. In assist control, the only work that the patient ever has to do is simply that minimal amount necessary to deliver, or rather to trigger the next breath. The tidal volume is always the set tidal volume, and overall this is a very good mode for resting the patient right at the time of initiating mechanical ventilation. Both assist control and IMV are volume-driven modes of mechanical ventilation, in that the ventilator has as its primary directive the delivery of a volume of gas, no matter how much pressure that may take. Pressure support and the next topic, pressure control, are both modes of mechanical ventilation in which the ventilator's primary directive is to deliver a set pressure into the airway tubing, regardless of what volume may actually be delivered as a result. In this illustration of pressure support ventilation, there is no backup rate on the part of the machine. Instead, the ventilator is only triggered to activity by the patient's initiation of a breath, in which case the patient breathes in and drops the airway pressure enough to trigger the machine to push in to a given set inspiratory pressure level. That inspiratory pressure level is set by the physician. As the machine pushes in pressure to meet that physician set inspiratory pressure level, flow will at first be high and will gradually reduce. Once the flow rate drops to 20% of the maximum flow rate, the machine stops pushing and opens the valves, allowing the patient to exhale. In pressure support, there is no backup rate. Each breath is initiated by the patient triggering the machine to push into a given set pressure level with whatever tidal volume happens to result. So the tidal volumes could be big if the physician chooses a high level of inspiratory pressure and the patient has normal lung mechanics. The tidal volume could be small if the physician chooses a small level of pressure support and or the patient has abnormal lung mechanics. The peak pressure is set by the physician, in that the maximum pressure the ventilator will ever deliver is the sum of whatever PEEP the patient is receiving with whatever inspiratory pressure level has been set by the physician. Hence, with the peak pressure determined by the physician, theoretically the risk of barotrauma might be reduced. In pressure support ventilation, the patient will do a variable amount of work of breathing, in that if you choose an adequate or high level of inspiratory pressure, the only work the patient would ever do would be the work necessary to trigger the ventilator, which is very minimal. However, if one chooses a small level of pressure support, the patient would augment the pressure delivered by the ventilator with negative inspiratory pressure generated by the patient, and that work could be excessive. In pressure support ventilation, the tidal volume depends entirely upon the combination of the patient effort and lung mechanics and the amount of pressure applied. Overall, one may achieve rest if you administer enough pressure, but one could also induce fatigue if one does not administer enough pressure. In addition, in most mechanical ventilators utilizing pressure support ventilation, there is no backup rate, and hence this would be a mode of ventilation to avoid in patients with a poor or fluctuating level of mental status, in that those patients may not actually trigger the ventilator. The main benefit of pressure support ventilation is that it by definition limits peak pressures. Theoretically, pressure support ventilation may also be more comfortable for some patients. Often, SIMV is combined with pressure support so that the physician can guarantee a backup rate of a given volume of SIMV delivered breaths, and if the patient desires additional breaths, the patient can initiate additional breaths which will be augmented in volume by the pressure set by the physician, excuse me. On the IMV breaths, there will be a set tidal volume. On the pressure support breaths, there would be a variable tidal volume. When used in combination, SIMV plus pressure support can rest the patient if one uses an adequate or relatively high level of pressure support. However, if one chooses a low level of pressure support, the work of breathing may be almost as high as if one were using SIMV alone. In general, the level of pressure support necessary to achieve an adequate tidal volume can range from as low as 5 centimeters of water to as high as 50 centimeters of water. And in an average patient, that level is more than 5 centimeters of water, such that if a physician chooses SIMV with pressure support of 5, those pressure support breaths will almost always be of an inadequate tidal volume. The last mode of mechanical ventilation we're going to discuss is pressure control ventilation. In pressure control, the physician sets a backup rate so that there is a guaranteed delivery of ventilation. Instead of the ventilator delivering a tidal volume, in pressure control, the ventilator pushes into the set peak inspiratory pressure. Unlike pressure support, however, this pressure is maintained for the duration of the inspiratory time as set by the physician. The concept behind pressure control ventilation is that by maintaining the peak inspiratory pressure for the length of the physician-set inspiratory time, there will be more time for gas exchange. One of the negatives, at least theoretically, of pressure control ventilation is that during any inspiratory, expiratory, respiratory cycle, if one lengthens inspiration, there will be less time for expiration, leading to the possible development of auto-PEEP. In pressure control ventilation, the peak pressure depends solely upon the amount of pressure being delivered by the machine. The tidal volume will depend upon the patient's lung mechanics. Pressure control ventilation is almost never used as an initial setting, but instead is used for settings of refractory hypoxemia or in settings where the physician specifically is concerned about limiting peak pressures. In addition, occasionally pressure control ventilation is simply more comfortable for the patient, but that is rarely the initial reason for using pressure control ventilation. And it's important when considering pressure control ventilation to remember that the prolonged inspiratory time may result in reduced expiratory time, leading to the potential for auto-PEEP. Since the desire at the time of initial intubation is to rest the patient, most commonly patients will use either assist control or the combination of SIMV with an adequate level of pressure support. And in general, within the medical intensive care unit, it is advisable to start with assist control unless there is a specific reason to consider alternatives. Regarding respiratory rate, if one begins with the backup rate of 12 and the patient is triggering in assist control, all those additional breaths will be of adequate size with minimal patient effort. Similarly, if one uses SIMV plus pressure support with an adequate level of pressure support, those extra breaths beyond the backup rate will be supported by the machine. Hence, starting with the backup rate of 12 is reasonable. If after the patient is stabilized, the patient is not triggering at all, one would want to consider a reduction in the backup rate to assure that one is not hyperventilating the patient. Conversely, if the patient is triggering excessively above the backup rate, one may want to increase the backup rate to further reduce the work of breathing. In terms of tidal volume selection, one could choose a rather large 10 to 15 cc per kilogram tidal volume if the patient has truly normal lungs. This could be utilized in the OR for general anesthesia, could be used occasionally in the medical intensive care unit for patients who are intubated for reasons outside of the lungs, i.e. patients who are intubated because they've had a stroke or they are in some sort of a coma, a drug overdose, where their lungs are perfectly normal and they are simply being ventilated while their neurologic status improves. In that setting, avoiding atelectasis would be a primary goal, and choosing a rather large tidal volume might be acceptable. However, in most medical surgical patients, a much more modest tidal volume of 7 to 10 cc's per kilogram is recommended. And in patients with significant ARDS, which will be discussed later, one may start with a small tidal volume of 5 cc's per kilo and even go down from there. It's important to note that in making these calculations, one should choose the patient's ideal body weight rather than their actual body weight. Hopefully this is intuitive, and that if a patient were to gain 100 pounds, their lungs would not get any bigger. Hence, in selecting tidal volume, that equation should be based upon patient's ideal body weight. So typical ventilator settings would start with assist control, a backup rate of 12, and for the 70 kilogram typical patient on which most medical calculations are based, that would result in a tidal volume of 500 cc's. Regarding the FiO2, most physicians would recommend starting with 100% FiO2 and rapidly reducing the level of FiO2 to a non-toxic level to avoid oxygen toxicity. Oxygen toxicity can develop quickly, or it could take several days. But rather than risking that possibility, one would reduce the FiO2 to the least amount necessary to maintain an adequate saturation as quickly as possible. What is often recommended is to reduce the FiO2 every 5 to 10 minutes as long as the patient's saturation by pulse oximeter remains above 92%. What counts as oxygen toxicity is not entirely clear, but most physicians would at least try to get the FiO2 down to 60% or less. In terms of PEEP, most physicians begin with a PEEP level of 5 centimeters of water and will increase that, if need be, to recruit alveoli and successfully reduce the FiO2 to a non-toxic level. Exactly the ideal PEEP will be discussed in another section. So if you began all adult patients on a cyst control, a rate of 12, a tidal volume of 500 with an FiO2 of 100% and 5 of PEEP, it would be a reasonable place to start, recognizing that your primary goal is to stabilize the patient and rest the patient, minimizing the work of breathing, as assessed by looking at the patient and identifying a patient who is not in distress, which highlights the importance of not forgetting about sedation.